So I'm absolutely delighted to begin this panel, very exciting panel with leading women's health researchers and their outstanding trainees that focuses on expanding women's informed choice and access to quality healthcare through digital innovations. And we're very lucky to have Dr. Ibukun Abejirinde here with us. Ibukun is a trained medical doctor and also a PhD in global health, and she's a scientist with the Women's College Hospital Research Institute and is looking very specifically at issues around digital health and equity, as well as having a long-standing research background in the area of digital and maternal child health. So without further ado, I would like to turn it over to our moderator, Dr. Abejirinde, to both share some of her comments and then to welcome in the first presentation. Over to you.
Awesome. Thank you, Dr. Kendall and the Partnership for Women's Health Research for this invitation to chair this very important conversation. And we're going to be talking about the intersections between digital health innovations and women's health. So for the next hour and a half, we'll discuss this theme in detail. We're going to have presentations. There will be a virtual panel. And Dr. Simone Vigod, Dr. Gina Ogilvie, Dr. Carla Prado, alongside their trainees, will share some of their work. There's going to be room for quick questions between presentations, but then we're going to save the more wholesome conversation during the panel discussion that will come later. So please feel free to put your questions in the chat box, and we'll get to as many of them as we can later on. So I'm going to share a few words from my own work before we dive into the main segment. And perhaps the goal would be that this will serve to ground our conversations today. I'll be speaking about the role that digital innovation can play to accelerate gaps in access, quality, and responsiveness in women's health, and why an intersectional lens could serve equitable design and implementation of such innovations. So in the context of tensions around political or investment priorities and dwindling public-funded healthcare, it's become common to be asked to make a business case for why certain interventions or population groups need to be prioritized in health investments. And so it was little wonder that this recent report by the World Economic Forum and McKinsey gathered a lot of interest and conversation. Their report put shocking dollar values on the implications of continued lack of research and action in the areas of women's health. According to the report, by addressing the gender health gap that currently exists, we could increase global GDP by at least $1 trillion annually in less than 2 decades. So essentially, they were saying that for every dollar that governments would invest in advancing women's health, we could be generating $3 in economic growth. But then what's the problem? Well, the problem is that making a business case does not necessarily shift societal norms. So this image came to light on social media a few months ago when we caught a glimpse into the persons who make up the House of Commons Standing Committee on Health in Canada. And the single woman that you see on the image, she's not the chair or any of the vice chairs of the committee. So just looking at this, you can imagine how the rest of the world is doing if in one of the most progressive countries on the Gender Equity Index in the world, where almost half of our population is women, we have only 8% representation on a parliamentary health committee. So my summary from this slide is that the business case on advancing women's health with or without digital innovation is not going to be solved without our addressing the systemic issues that affect representation and inclusion of women. And for the panel and the conversations we're about to have here today, I'd like to say very proudly, actually, that we're in pretty good company. So in the landscape of accelerating progress towards digital innovation, interventions and advocacy targeting women's health collided quite timely with exponential advancements in the use of technology in healthcare. And this ranges from basic mobile health and app-based tools or wearable technologies to more advanced AI-driven machine learning algorithmic models. And this has shaped a very niche area that is now known as femhealth, which is used to describe all technology-driven solutions that focus on women's health, where they're using data, advanced analytics to design responsive and integrated end-to-end care pathways that specifically focus on women's needs. So January this year, the FDA in the US, for example, approved the first and only of its kind diagnostic menstrual pad. Last year, they gave approval to clear the first ever digital contraceptive. So while reproductive health and access actually tops the list of focus areas in femtech and women's health, advances are also being made on research and innovation to address gaps in other areas. So priority areas like health education, cardiovascular health, cancer, even targeted pharmaceutical-based solutions that are more responsive to how women experience clinical conditions differently. So if you think of gender-specific and precision medicines. As we're promoting the use of innovation, though, to address the health gap or the gender gap and focus on critical issues that are distinctly unique or distinctly experienced by women, I think there's an imperative for us to recognize that women embody various overlapping and intersecting social identities. And so that shapes how and in what combinations they experience discrimination and privilege within society, and I guess more pertinent to our conversation today in healthcare. These differences we know are defined by social categories and stereotypes around race, ethnicity, religion, immigration status, weight or body composition, differing abilities, and, using a more popular terminology of the social determinants of health, the intersections manifest under the conditions in which people are born, grow, work, live, and age. And so while these determinants are non-medical, and in many cases, largely beyond an individual's control, they are actually quite powerfully deterministic in influencing how a woman experiences healthcare services and the outcomes that she gets from that care. So intersectionality, I believe, is a necessary tool within the conversations around digital innovation for women's health to help us understand complexities and layered nuances that explain between group and within group gender disparities. And we can be using it as a compass to guide how, why, and for whom questions as we try to solve for healthcare using women-centric digital innovations. So the kind of questions I imagine we'll be asking is, how do we use technology to solve for the fact that Black women are 41% more likely to die from breast cancer than white women? Or if you think about the gender paradox, which is where women live in worse health but live longer than men, and then you combine that with the healthy mortality paradox, which is defined as immigrants living longer but in worse health than native-born persons, what does access to care mean for an immigrant South Asian woman to Canada? I feel like those are the big questions that we're trying to solve and that the presentations will talk about today. So I'm going to close by speaking about the work that Nobel laureate Amartya Sen did, where he introduced the concept of missing women. And that concept was used to describe women's disadvantages relative to men in overall mortality data. And he explained that the reason for this is because of gender inequities in access to medical and social innovations. And he noted that women, particularly those who live in poverty, face multiple layers of disadvantage that stifle their opportunities to survive and thrive. So my call to all of us today, as we continue to make rapid advancements in a digital and information age and in healthcare, to be mindful of the unique variations in the experiences and needs of women, and to think through what this means for how we design and deploy innovation. How do we center the individual in the algorithm? and to note that it's going to take more than digital technology and AI to address social injustice and inequity. So I'm going to leave you with two images. On my left is a graphic recording from a study I've been leading to understand the role and meaning of compassion for newcomers and refugees to Canada who are receiving virtual care. And then on the right is a fictional but original image of a woman that I've called Mariama. When I was doing my field work in Ghana, trying to understand how digital technology can improve maternal health in low resource settings, her untimely death, despite having access to the technology, actually shaped my understanding of the data that I was collecting. And while I won't go into the details of her story today, I think this image has served as a constant reminder to me for why the work we do and the conversations we're about to have today are extremely important. So with that, I'm now going to pass the microphone to Dr. Simone Vigod and PhD candidate Neesha Hussain-Shamsy. Dr. Vigod is a senior scientist at Women's College Hospital Research Institute, where she heads the Department of Psychiatry. She's also a professor at the Department of Psychiatry and the Institute of Health Policy Management and Evaluation at the University of Toronto. She's a leading expert in perinatal mood disorders, having conducted some of the world's largest studies on maternal mental illness. Neesha Hussain-Shamsy is a PhD candidate in health services research at the University of Toronto's Institute for Health Policy Management and Evaluation. And her research interest is in the use of virtual care to deliver quality, effective mental health care, particularly to those who are pregnant or postpartum. So before, I'm going to quickly say Simone will have to leave for another commitment soon after their presentation. I will not be able to stay for the panel. So I think it'll be good to take any burning questions for her before she leaves. Over to you, Simone and Neesha.
Thank you so much for such a kind introduction. I'm really thrilled to be here. And as Dr. Abejirinde said, I'm going to give the talk part now, and then I'm going to give Neesha the hard work of being on the panel later. But Neesha and I have worked together for many years, and she's been involved in and through her PhD has worked a lot with us. So what I was tasked with in the next 13 minutes is to tell you a little bit about the work that we do at Women's College Hospital in the Department of Psychiatry, and to focus in a little bit on some of the work that we've done in digital health around perinatal populations. So let me just figure out how to. There we go. So I have some disclosures and just wanted to put up here the funding for some of the research that I'm going to present about. So the Department of Psychiatry at Women's College Hospital is probably one of Canada's largest clinical and research departments of psychiatry that really has a special focus on the mental health of women. So we have a program called the Reproductive Life Stages program that really focuses on issues unique to being of female sex, like mental health issues around the menstrual cycle, pregnancy, and the perimenopause. And then we also have programs that really focus on issues that either are unique to women and non-binary and trans persons, or affect them in in unique ways. But what I'm going to talk about today is really this focus on the perinatal period, as Dr. Abejirinde noted. So just to set the stage a little bit of why we're thinking about this. So in Canada, there are close to 500,000 births every year. And there's some pretty good data to suggest that up to 20% of pregnant postpartum people are affected by some kind of perinatal mental health issue. The most common issues are depression and anxiety symptoms, but there are also other psychiatric disorders like obsessive compulsive disorder, post-traumatic stress disorder, and then more rarely bipolar disorder, psychotic disorders. Really, there's nothing, any psychiatric disorder can occur around the time of pregnancy, and then there are really specific issues that we need to think about to make sure that the birthing person and their child and their family gets the care that they need. We have a problem, though, in that it has become pretty clear that for various reasons, 1 in 5 people, oh, I'm sorry. It's actually 4 in 5 people. Only 1 in 5 people receive the care that they need to resolve their symptoms. Oh, see, I have an error on my slide deck. I apologize. And there are a lot of reasons for this, right? Some of it relates to lack of knowledge about these disorders, about the fact that they're treatable. Some of it relates to kind of shame or worry about being discriminated against, but there's pretty good evidence to suggest that a big part of this is simply about lack of timely access to treatment. Because the good news is that mental health issues that occur around the time of pregnancy are highly treatable. So people with mild symptoms, there's emerging evidence around exercise. There's really good evidence around peer support and non-directive counseling for people who have, slightly more severe symptoms, who maybe would fall into the category of a psychiatric disorder. First-line treatments are fairly actually short courses of psychological therapies like cognitive behavior therapy or interpersonal therapy. And then when we get to maybe more severe illnesses, sure, that's where we're starting to talk about medications, which also can be really effective. But it's really not uncommon, in my clinic, and I work as a psychiatrist in the reproductive mental health clinic that I talked about, for people to come in and say, to be 8-9 months postpartum and say, I've been struggling since my pregnancy, but, I wasn't sure. I thought maybe, I just shouldn't feel this way. I felt ashamed. I wasn't sure anything could help me. And then the baby came and I was just exhausted and I didn't even know who to talk to or about what and when. And, even the idea of coming to see you is like, I have to wrap my baby up in the Canadian winter and there's nobody to watch the baby and I need to get on the subway and I need, you could just imagine all these kind of competing demands. And then on top of that, there are these fears of, oh my goodness, what if the psychiatrist says I need to take medication in pregnancy? And what's that going to do to my baby? Or during lactation, what's that going to do if it passes through to the breast milk? So there's just this kind of conglomeration and in qualitative studies, people just describe it as this like house coming down on them of things that, are preventing them from getting care. And speaking to what Ibukun said in the beginning, there are going to be specific populations who may be at higher risk of having difficulty with mental illness, probably related to disparities in social determinants of health. And then those same populations may be at even more risk of not having access to the kind of culturally acceptable, safe, effective care that they need. So there are lots and lots of reasons why 4 out of 5 people who are suffering are not getting the care that they need to get better. So listen, we're here today to talk about digital health. Digital health is certainly not the only solution, but the way that we have thought about it in our program, this is a kind of a model of care that Women's College Hospital was, playing with in its last strategic plan to kind of say, like there are lots of levels at which we can do digital. We can do digital in, triaging people. We can do digital things to help people get sort of care on their own. We can use digital to connect different providers. We can do, we can use digital to be directly, working with patients. But all in all, it's exactly what Ibukun said, which is, we're not using digital for the sake of digital. Right? We're talking about using digital health or leveraging digital health to solve problems. So it's not going to be, I saw in the amazing cartoon that Ibukun put up, there was a little thing that somebody had written there, like it's, digital care is an option. It's not the option, right? So the question is, are there ways in which we can leverage technology and leverage digital to fill the care gap? To fill the gap between what we know works and what we are actually doing. It does not mean that it's going to fill every care gap for everybody, right? But maybe it can fill the gaps for the people, who want and need to use them. So what I'm doing now is really going to show you just this sort of smattering of work that we've done that, just to sort of raise awareness and discussion of some of the stuff that we've done in our research program. So this app, the PPD ACT app, the Postpartum Depression Action for Causes and Treatment, we were part of an international study where we went out across Canada and people could download this app that would screen them for postpartum depression, either currently or they could have had it in the past. And so if they screened positive currently, we were able through the app to direct them to treatment and care in their region, which was like really neat. And it was, it's pretty anonymous. But then they also had in a part 2 the ability to, if they screened positive either now or previously, to consent to sending us genetic samples. And we sent them a spit kit, like a saliva collection kit in the mail. And we piloted it to see, how many people we could get. We had about 1,200 people use the app in the course of a year, and 400 people sent us genetic samples. And we've published on this now, on our own with the Canadian data, and then also with the International Research Consortium to try to understand things about, what's the genetic risk for postpartum depression? Because imagine if we had a biomarker and we could tell people beforehand, to prevent, or maybe there's a treatment that we could develop based on what we find. So that was, I'm not a genetics person, but I really learned a lot about, I thought I put it in here because I really learned a lot about like how we could find people, and, and it was really interesting to me how many people actually really wanted to contribute to the genetics. It just shows like how much of an issue this is and how much people really want to solve it. And then we've done a lot of work in our clinical program. You remember the staircase I just showed you to kind of take people from the psychological treatments up through the medication treatments. And so about 10 years ago now, we developed Mother Matters, which is a therapist-facilitated online postpartum therapy program where where people can log on to the website 24/7, and then therapists moderate during the day. And we did a pilot study of over 100 people in Ontario, and we got people from all regions, which is really important when you're talking about, the ability for digital to leverage for remote management. And we actually showed that in people with more severe symptoms, they did much better than a waitlist control from this just on its own. And what's really exciting is we've been looking for funding to redevelop the app, and we, to make it more modern. And so we received a donation work we've just started on now, where we're working with several community groups to develop. We're going to still have our regular sort of all are welcome group, but based on a needs assessment, we're going to be developing new content specifically for Black populations and for adolescent populations, so that we can deliver these sort of more specific groups, and we're going to be evaluating that. We've done a lot of work over the years on, one-on-one virtual psychotherapy and virtual psychiatric care in a more live forum. Neesha may tell you later about her PhD work, where we had an in-person postpartum psychotherapy group that with the pandemic, we flipped into virtual, and Neesha led the evaluation on that. And that I think came, with some really interesting learnings about who it was good for, who it wasn't, what were the trade-offs of, of doing a group like this virtually. And we've been involved now with some major trials. Dr. Daisy Singla is leading a major trial across 5 sites across North America, looking at virtual versus in-person psychotherapy, and also comparing like a mental health expert provider to a perinatal nurse or midwife trained in it. So that's been really neat. And then, thinking about the top step, we've talked about medications and the fact that people need to make decisions about what to do about medication use in pregnancy. So using the Ottawa Decision Support Framework and the International Patient Decision Aid guidance, we developed an online decision-making tool that people can use and go through, and it helps them understand, why might I take this? What are my different treatment options? What are the risks and benefits of, exposure in pregnancy? What's helping me make my decision? What do I value about this? What do I not value about this? And then they could take that information to their prescribing doctor, because you can imagine, like I work in a specialty center, but there's about 40 to 50 articles published every single year about the safety of antidepressants in pregnancy. Like, I'm not sure how any sort of primary care provider could be expected to keep up with that. So this is sort of an idea of like, can we give the information out and then people can go and take that and talk with their prescribing clinicians. And so we've just finished recruitment for a large RCT where we're looking at not only does this help people make decisions, but then what happens to them over time? Like, do they actually have lower rates of depression and postpartum depression? Like, we don't tell them what decision to make. Stay on your meds, don't take them, don't. Like, people will make their own decisions, but are they making the most effective decision for them? And we had this tool was actually taken up and also evaluated and adapted by researchers in the National Health System in the UK, which was really neat to get, that perspective and get it out internationally. So now, the big thing we're working on is pulling everything together into a system where we actually are developing a web platform. We call it MOVEN, the Pregnancy and Postpartum Mental Health Virtual Intervention Network. And where we're saying, okay, can people come in? Can they self-screen on our website? And then can we get them connected with, a care coordinator who can help them figure out what's the best kind of resource for you? Might it be virtual? Might it be not virtual in your community, culturally appropriate and specific, and getting people to where they need to get to. But then if they actually need something a little bit more medical, like around medications, helping to connect their family doctor or their antenatal care provider with an expert reproductive psychiatrist. And then if things are really not going well, actually having someone like me do a full psychiatric consultation and bringing people into one of our programs, right? Because there are just so many people. Like, if you think about, 400,000 births in Canada every year, if 20% of people need mental health care around the time of pregnancy, that's like 80,000 people. So we can't just put them all in a lineup for specialized psychiatric care. We need to be thinking about, like, some people don't need that. So how do we arrange the system so that we can get people the care they need when they need it, instead of this kind of lineup that happens right now where like everybody's in line and it doesn't, and then a lot of people wait a really long time. And so we did a pilot study of this. This is just kind of what it looks like, but I already explained it to you. Like, you do the app. If you have a high score on the Edinburgh postnatal depression scale, you move through the pathway, and we monitor people over time, and they download the app, and this is what it looks like. And so here's some, like, you go in, you can look at your score, you can schedule a call, and then you get a personalized email, and then there's all these different resources. And we worked with a company, and we had a diversity advisory committee, and we worked with a company that actually helped us do a diversity audit, which was really interesting, like around language, around presentations, around images, and worked with a whole bunch of patients. That was really, I think, one of the most incredible experiences that I've had, like really things that, you wouldn't necessarily always think about. And so the neat thing is we actually we had a small donation to add to our grant to actually implement some of that, which was phenomenal. And then the care plan is in the app. Everything's crossed out here because I'm not showing you a real person stuff, but you can have in your app, what's been recommended. You can chat with your care coordinator, and then we monitor you over time, right? Like how you've been feeling, do your symptoms again. And then we did a pilot, and we actually recruited about 100 people, 101 people in 6 months. And remember, 50% of them were agreeing that they would be randomized to essentially usual care, which is we just told them some resources. And we wanted to see, like, who did we get and what did people think of the app, and, how did it work just in this small number of people. And, I won't belabor it, but in the move-in group, most of the people logged into the move-in site. So some people didn't, and some people never will. But of the people who logged in, they all completed their scales. Almost all of them took a call with the care coordinator. But what was really neat was that, except for 2 of them, and 2 of them who had consultations with the primary care provider and 3 who had a direct consultation with the psychiatrist, everyone else was managed with community resources. And 12 weeks later, we had remission rates that were favoring the move-in group by 20%. And then at 6 months, favoring the move-in group by 25%. So it's not the people, who get usual care in our system don't get better at all, and, might be with time and they do get services. But all we did here was give people resources, some care coordination, some support to figure out like what really might work best for them. And we got a dramatic difference. And so we actually just found out a couple of weeks ago that we've been funded by CHR to conduct a large RCT for move-in, and we'll be launching that soon. And we have a patient panel, and we have people actually from across the country to think, if we can do this in Ontario, and we've got now 5 of the big hospitals in Ontario's perinatal psychiatrists are going to be like on a rotation to help with it. And we're going to hire care coordinators. If we find that this can work system-wide in Ontario, then this could really help with getting people the care that they need. So I hope that this was, I went a tiny bit over with time, but I hope that this was just a little bit of, knowledge about the kinds of things that we're thinking about in our program. And we hope that our work can maybe, function a little bit as a lab for other people to, to take these ideas and, either use our, that is one thing about digital, like it actually takes a really long time to create these interventions. And like, we're not tech companies, right? Like we're researchers and clinicians. And so, I think the more that we can share this stuff and adapt it versus having to do it from scratch, I think will really help us out a lot. I want to thank a million folks around this, and really couldn't be done without our advisory committees and our tech design partners and our investigators and our research personnel support. So I will stop there, and I think we probably don't have time for questions, so I'm going to have to put it all to Neesha.
Thank you so much, Simone. And I agree. I think Neesha is going to take it away. The question I actually had burning on my mind, you answered, because it was about sort of bringing in that diversity lens and designing innovations for a wide variety of populations. We know you have to leave, and we'll let Neesha carry on behalf of your team. And next, I would like to hand it over to Dr. Gina Ogilvie and Nadia Mithani, who are going to share some insights from their ongoing work where digital platforms are being used to increase screening rates for cervical cancer. Dr. Ogilvie is a professor at the School of Population and Public Health, University of British Columbia, and she's a Tier 1 Canada Research Chair in Global Control of HPV-related diseases and their prevention. Nadia Mithani is a current PhD student at the University of British Columbia in the School of Population and Public Health, and her research is on the acceptability and uptake of HPV-based cervical self-screening amongst underserved populations. Over to you, Dr. Ogilvie and Nadia.
Thank you so much, and thank you so much for the invitation. It's just delightful to be here and to actually be part of Power, and having watched its journey of coming together. It's a really tremendous opportunity, and I know this is kind of the vision that we had of bringing people across the country together to talk about key health issues for women. So thank you, Tamil, for your leadership and for this great work. We're really delighted on behalf of our team to present some of our work on leveraging digital platforms to improve cervical cancer screening rates. So next slide, please, Nadia. So just by way of context, these are some of the sort of backgrounders around cervical cancer. So globally, 1 woman dies every 2 minutes of cervical cancer. And in 2018, there were about 300,000 deaths due to cervical cancer, and 90% of those occur in low and middle income settings. I think what's particularly egregious for many of us in this space is that cervical cancer is largely, virtually entirely preventable. And it's preventable through vaccination for those who get it prior to acquisition of HPV, but it's also preventable through screening and treatment. And we've got very effective screening tools to detect those precancerous lesions that can then go on to cancer and to treat them. And even when you have an early diagnosis of cervical cancer, that can be effectively treated. So elimination of cervical cancer is within reach for all countries. And as one of the leaders of WHO has said, there ought not to be any cases of cervical cancer, yet we have over 300,000 a year. Next slide, please. And so the WHO has named cervical cancer as a public health priority, and they have adopted these goals to help achieve elimination by the end of the century, to have 90% of girls fully vaccinated with HPV vaccine by age 15, having 70% of women screened with a high performance, and that it means a molecular test by 35 and 45, so twice in a lifetime. And then those who have been identified with cervical disease to receive treatment for precancer and for invasive cancer as well. Next slide, please. In Canada, the Canadian Partnership Against Cancer has taken leadership to set our Canadian goals, and many of us were delighted to be involved in this and to see Canada name such bold and strong goals that align with this elimination target of the WHO. Our goals in Canada are to make sure that 17-year-olds are fully vaccinated with the HPV vaccine at a rate of 90%, that we have 90% of eligible individuals screened with an HPV test by 2030, and that we ensure that those who have screened positive, in this case, positive HPV results, actually get that treatment that is needed. Next slide, please. And one of the key things, and we talked at the beginning about the key roles of intersectionality, and I think that's one of the key things here with cervical cancer. In 2022, about 1,500 Canadian women and individuals with a cervix were diagnosed with cervical cancer, and about 380 died. So just to be really clear about this, once a day, a Canadian family is losing a very key valued member of their community and their family from a preventable cancer. And in British Columbia, if we think about that second goal, the screening rate, about 68% of folks who are eligible for screening, women and individuals with a cervix, about 68% have been screened. And remember, we're aiming for a 90% goal, so big gap there. But in the Fraser region, where it's in British Columbia is a large South Asian population, only about 63% of eligible individuals have received screening. So there are barriers to screening, and those exist, and those include things like not having a female healthcare provider, history of trauma and abuse, embarrassment, the difficulty of getting time off work and childcare, historical and structural concerns, cultural beliefs and language, and long commutes and wait times. And those all combine together to make cervical screening a challenge for the community, and particularly where we're looking at in the Fraser Health region for the South Asian community. So we really need to think about novel approaches to engage women who do not participate in screening. Next slide, please. So one of the big opportunities we have is actually this transformation from Pap screening to HPV-based testing. Traditional Pap screening or cervical screening required women to first visit a provider. They had to undergo a speculum and vaginal examination and cervical examination. And we also know the technology itself was of lower accuracy. So that's cervix screening, and that's what we've built our program out on. We now have a substantial transformation with the use of HPV testing. HPV looks for the infection that precedes the transformation of the cervix. So the sample can be collected anywhere. It doesn't have to be collected at a clinic. The person can collect the specimen themselves by doing a vaginal sample, and it's accurate, safe, and painless. And it's actually more accurate than Pap screening. So it's a really transformative change in cervical screening, and it opens up huge opportunities for innovations and improvements in access. Next slide, please. And Nadia, I believe this is now over to you, right?
Yes, thanks, Gina. So we designed and implemented Cervix Check Fraser, which is a research study that was meant to offer HPV self-collection through a digital platform. And it was implemented in partnership with 8 family physicians in the Fraser Health region of BC, which Gina mentioned has lower screening rates and is primarily a South Asian immigrant population. And so many of these family physicians were also from the South Asian community. Cervix Check Fraser was embedded in a primary care model. So patients would see their physician, and if they were due or overdue for screening, then they were invited to register. for the cervix check study and through the website. And this is a photo of Dr. Nadia, who's one of our partner physicians and a community physician champion. So she sees firsthand a lot of the barriers that these women face in Pap testing, and she receives a number of referrals, especially from her male physician colleagues. And so she was instrumental in implementing cervix check Fraser according to the needs of this population. So with cervix check, we actually leverage the successes of Get Checked Online, which is an existing digital platform for STI testing. However, we made it unique to cervix screening. And so in 2019, we built a website where persons with the cervix could register for at-home HPV self-collection. We also conducted a digital health literacy survey to see if the digital approach would actually work in this population. And this was done with 51 women aged 30 to 65 from 4 of the participating family practice clinics. And to show you some of these results, so we found that over 90% of women felt comfortable reading and understanding English. 82% were accessing the internet almost every day. And 80% were somewhat or very likely to participate in cervix check. So this showed us some initial acceptability that the digital approach could work in this population. On the right here, you can see a screenshot of the cervix check website. So if participants were eligible, meaning that if they were age 30 to 65 years of age, were considered underscreened, so hadn't had a PAP in the last 3 years or more, and were also from the partnering family physician clinics. So as long as they were eligible, they could go online, create an account. They would then be mailed a self-collection kit to their home. They collect a sample in their home and they mail it back to the provincial lab for HPV testing. They were then provided their results online and then invited to complete a feedback survey. So just to show you some images, so on the left, this is what the patients would receive at the clinic. They would get a registration code, which they use to register on the website. And again, a summary of the process. So creating the account, verifying their screening history, signing consents, receiving the kit, collecting the sample, and they received instructions to do so and could opt to receive their instructions in Punjabi. They then mail the kit off to the lab. And then once the results are ready, they log back into the website and could check their results. And all this was done within 15 days. This is also a screenshot of the results page that the patient sees, so they could see the result and also receive a bit more explanation on what the results mean. So since the study started in April 2019, 193 participants self-collected and received HPV results. There were a total of 377 registrations. However, there were a number of ineligible registrations and about 67 unreturned kits. But most importantly, 92% of participants who were HPV positive attended their recommended follow-up. And with the feedback survey, 22% of participants completed it, majority of whom were between age 40 to 59 and who were comfortable communicating in English. And they mentioned that common reasons for participating in cervix check and self-collection was the convenience and comfort of it. And with respect to the digital platform, 83% were satisfied with using the website, and 88% felt satisfied receiving screening results online. Now, cervix check was also implemented in northern BC, where we have several First Nations and Métis communities, most of which live in rural and remote communities, which means they have additional barriers to healthcare access. And the cervical cancer burden is disproportionate in Indigenous communities. First Nations women in BC are 92% more likely to be diagnosed with cervical cancer. And they face a number of barriers to Pap testing, a number of which are unique to Indigenous women. So on the left here, you see a map of BC, and you can kind of see where some of the First Nations and Métis communities reside. And for Cervix Check North, we partnered with 3 Indigenous programs. Carriers Academy Family Services, the First Nations Health Authority, and Métis Nation. And Cervix Check North and the partnerships with the Indigenous programs were really grounded in OCAP principles, meaning that these three programs really led the planning, implementation, data collection, evaluation of this approach, and meaning that they also employed a different approach for implementing HPV-based self-collection because it was really based on the community's needs. So for example, Métis Nation BC opted to use the digital approach and the Cervix Check website. However, instead of the primary care model, they engaged participants through a number of community-based activities. And this resulted in 71 participants across 9 communities from October 2021 to present. The other 2 programs, Carriers Academy Family Services and FNHA, opted not to use the digital approach, as they found that there was lack of internet connectivity across their communities, low digital literacy, and they really just found that the digital approach would take away from the personal and community-based nature with which they currently provide healthcare. So this kind of goes to show that there is no one-size-fits-all when it comes to HPV self-collection, and the digital approach may not work for every population. I'll now hand it back to Gina to talk to you more about self-collection in BC.
Thanks, Nadia. So based on this and several other large research projects that we've been leading in British Columbia, we were pleased to be able to launch a self-screening pilot for the province of British Columbia in December in 2021. This was grounded on the concept that HPV self-collection is a safe and accurate alternative to provider-collected sampling. And really what drove us with this interest was they had the opportunity to improve cervix screening uptake, particularly for those who are under-screened. So we were able to secure funding from CIHR to actually launch a large pilot program in about 4 regions of British Columbia with the goal of improving cervical screening coverage and to compare the effectiveness of an opt-in and an opt-out invitation for screening. Next slide, please. So women and individuals with a cervix aged 25 to 69 were selected from the BC client roster, which is the roster of everyone with a personal health number in British Columbia. And if they were in the select communities in the province, we established their eligibility and their whether they were part of that cohort through a linkage between the provincial database and the screening database. What that did was query against the database of the ministry who was in the cervix screening database. If the two didn't exist, then weren't in both screening databases, we then knew that those individuals had never been screened. So they were in the never screened group. We also then were able to look through the cervix screening program for those who were significantly overdue and due for screening. And one of our key things with all of our health research here with our team is to really evaluate programs that could be integrated into the health system. So we really are committed to doing and examining approaches that the health system can adopt, not approaches that would require substantial shifts in the health system. Next slide, please. So what we did was we invited 3 cohorts, or we collapsed into 3 different cohorts. So cohort 1 were those who had never been screened or their last screen was more than a decade ago. Cohort 2 was those who were overdue for screening. Their last screen was 5 to 9 years ago. And cohort 3 was those who were due for screening. So it had been routinely engaged, but were due for screening because their last screen was in 3 to 4 years. Next slide, please. We then invited all the cohorts. There were different ways we approached. There was what we called opt-in. So a pre-invite letter was sent to say, this invitation is going to be coming to you, and tell us if you don't want that invitation to come to you. And then we'd send them an invitation saying, you're eligible for cervical screening, and here's how you can request a kit. And they could request a kit online through email, or they could phone the cervical screening program. We sent a reminder 28 days after, and if the kit was requested and hadn't been returned, we sent a reminder 49 days after the kit was sent. So that's opt-in. Opt-out was that a pre-invite letter was sent, and then instead of sending an invitation to request the kit, we actually just directly sent the kit. And we sent it 21 days later if they had not called us and said, I don't want the kit, or emailed us. And then once they got the kit, we again sent a reminder letter 49 days after and said, hey, you've got this kit, don't forget to return it. And then the direct recall, which is for those who are actually due for screening, we just sent a reminder screening letter and included a self-collection kit and one recall letter as well. Next slide, please. This is what the products looked like, and this was one of the things that was helpful doing our pilot project was we were able to pilot test things, get feedback from clients, from different users. And so it's a very, it's a small kit, and it just includes, as you can see, a swab right in there with all the information, including frequently asked questions, diagrams, an envelope, and a plastic bag that you put the kit in, that you put the swab in, and you can pop the kit in the mail. Next slide, please. So just at a very high level, these are results from July of this year. You can see that in cohort 1, so remember cohort 1 is the never or greater than 10 years. In the opt-out, so those who directly got the kit, 23% returned their kit. In the opt-in, so where you had to either phone or request to get 10% return. And I think I just want to always underscore with cohort 1, these are folks who, many of whom have never been screened, and we now were able to get screening from them. Cohort 2, you can see here, we had an opt-in return rate of 28%, and then an opt-out return rate of 28%, and opt-in of 15%. And then you can see with cohort 3 that we had the direct opt-out and opt-in return rates. I think what's important with cohort 3, just to underscore, is that for both the letter to request the kit, but also for the direct kit, for many, it was actually just a catalyst to actually go and see their practitioner. This is a group of regularly screened folks. So the kit was both returned, but we also saw a number who actually soon after ended up having their pap smear and visiting their practitioner. So I think what's important here is that opt-out had almost a doubling of return rate compared to opt-in. However, opt-out, of course, was substantially more expensive because we had substantial more waste where folks had a kit sent to them and it wasn't returned. So environmental considerations, cost considerations with that as well. Next slide, please. We've done a survey, and I'm just going to highlight very, very quickly that you can see there's a lot of confidence with self-collection, highly recommended to family and friends, satisfied with the information in the kit. The kit information instruction sheet was clear, easy to understand. People were comfortable, and they were confident that they could do it. So, really well received by folks across the province. Next slide, please. And so we were very pleased in January of this year to launch the cervix self-screening program in British Columbia. So we've transitioned from pap screening to HPV-based screening. Folks who are eligible can either request a kit online, or they can go to their practitioner and get HPV-based screening there, either through a pelvic exam if they choose, or actually a vaginal exam, either that the practitioner can gather, or they can do it with the support of their practitioner. And we were very fortunate that data from places like Cervix Check Fraser, Cervix Check North, and also our pilot program all help to offer confidence, guidance, and direction for this substantial provincial transformation. Next slide, please. So just to summarize, Cervix Check is an innovative digital approach for self-collection, and with a real focus on equity and ensuring that we enhance screening coverage in the community for South Asian women. And our findings were very clear that a digital approach was very acceptable and feasible, and that engagement with healthcare providers and patients offering various approaches, and that's what we're really committed to, really offers different ways, different avenues, different entry points for cervix screening. And the Cervix Check program really provided us with a foundation to move to a bigger pilot and ultimately to our provincial transformation in cervix screening. And of course, massive thanks to everyone. Particularly want to just shout out the team in Vancouver, the team up north, Shona and Mitchell, the team with Métis Nation, Tanya and Katina, and all the folks who were in the community leading this work. Thanks very much.
Thank you so much, Dr. Ogilvie and Nadia, for very impressive work that you're doing, and also just sort of sharing how you've made it into a targeted approach, recognizing that different communities have different needs. I do see one question has come in, but we're going to save that for the panel so that we quickly move on into our last presentation prior. So it's my pleasure to now hand the stage over to Dr. Carla Prado, who has pre-recorded her presentation for us, as well as her trainee, Camila Orsso, who's here with us today. Dr. Prado is a full professor at the Faculty of Agricultural, Life, and Environmental Sciences at the University of Alberta. Her research looks into the interrelationships between nutrition, metabolism, muscle fat distribution, and health. Presenting with her during this segment is Camila Orsso, a doctoral student in nutrition and metabolism, who is investigating the efficacy of multimodal and digital interventions to improve the health of individuals at risk of developing cancer and those who have survived endometrial cancer. Over to you for the presentation.
Hi, everyone. Thank you for joining us today. I want to thank Dr. Kendall for this invitation. Thank you to the Partnership for Women's Health Research. Dr. Kendall has really been a trailblazer in the realm of women's health and rights, and it's a great honor for me to join this event. I sincerely apologize for not being able to join the event live. I'm currently en route to a conference, and unfortunately, there was a scheduling conflict with my flight, even though I had this event in my calendar months in advance. So I apologize for that. And today I'm going to be sharing this presentation with Camila Orsso, who is my PhD student and has been a great advocate for women's health as well. So a large portion of what we work on in my lab is related to body composition and optimizing body composition, which refers to the amounts of fat and muscle in our body. And I love to use analogies, and an analogy to abnormalities in body composition can be used or done using a pomelo and an orange as an example. So if you've seen a pomelo before, pomelo is this very large fruit, but when you peel the pomelo, the amount of fruit on the inside is actually quite small. So compared to a cross-sectional area of an orange, you can see that a pomelo, the amount of fruit is much smaller compared to what you can get from an orange. And the same is true for our body composition. What's on the outside does not tell us what's on the inside. So at any given body weight, people can have exactly the same weight, but have very different proportions of muscle and fat, and muscle is depicted in red in these figures here. So you can see that at the same body weight, people can have very little muscle mass, average muscle, and a lot of muscle. And on the other end of the distribution, you can have people with low muscle mass at any body weight. So low muscle may be a hidden condition in people who have normal body weight or people who have overweight or obesity. And we're particularly interested in studying this phenotype of body composition, which is high fat mass concurrent with low muscle mass. And this is called sarcopenic obesity. And sarcopenic obesity is associated with a variety of clinical consequences. It's related to a high risk of mortality, of morbidity, metabolic impairments. So we really get the worst from the high fat mass and for the little muscle, which muscle is so important for function, but also has very important metabolic roles in our body. And when people have other conditions such as cancer or other diseases, sarcopenic obesity is also the worst case scenario, as well as for older adults, because you have the consequences of obesity and low muscle mass. So we try to address and study sarcopenic obesity in different conditions, including in cancer. We're very dedicated to cancer research and cancer survivorship in our lab. And today we're going to talk about a study that we have, one of the largest studies in my lab, which is looking at endometrial cancer survivors. And endometrial cancer is a type of uterine cancer that affects the endometrium. It is the fourth most common cancer type among Canadian women. And the histologic subtype, type 1 endometrial cancer, is the most common histologic subtype. It's actually prevalent or present in about 80% of the cases. And because most cases are diagnosed at an early stage, thousands of women survive endometrial cancer each year. And a lot of these women have a high BMI or have obesity. And in fact, people with obesity are 10 times more likely to develop this type 1 endometrial cancer, which is estrogen associated. And this figure is showing that endometrial cancer rates are rising in developing countries, including Canada and the United States. And in fact, it's one of the few cancer types with rising incident rates. It has the highest incidence rates in Canada and US. And again, the prevalence or incidence continues to increase. And it is also a cancer type that is associated with the highest burden of comorbidities, so obesity, type 2 diabetes, hypertension, metabolic syndrome, cardiovascular disease, among other conditions such as hypertension, as well as metabolic syndrome. And these multiple comorbidities are linked to higher non-cancer related mortality, which is very important for these women. So women with this type of cancer are surviving longer. It's a treatable cancer, but also they have the highest or a very high burden of comorbidity, one of the highest burdens of comorbidity. So survivors of endometrial cancer really have a number of factors that may ultimately even lead to worse outcomes or worse health outcomes. They have excess in abnormal fat distribution. So not only they present with obesity, but also the fat accumulation in the abdominal region. So elevated waist circumference, for example, is associated with poor outcomes. We know that it's associated with insulin resistance, inflammatory milieu, a variety of other factors. Likewise, this cancer type or women surviving endometrial cancer also are at greater risk for presenting with low physical activity as well as poor dietary choices. And they also can develop or are at greater risk for developing the sarcopenic obesity phenotype that we've mentioned before. So the sarcopenic obesity phenotype is again associated with high fat mass concurrent with low muscle mass, and that can also be associated with low muscle strength. And this figure shows a large study that looked at the risk of death from heart disease among different time points following a cancer diagnosis. And you can see here the different types of cancers. In orange, you have endometrial cancer. And you can see that endometrial cancer was associated with the greater cardiovascular disease mortality risk at all time points, evaluated post-diagnosis up to 10 or more years. And at this time point, so 10 or more years, cardiovascular disease or the risk of cardiovascular disease was 6 times greater than that compared to the general American population. And if you look at the very first time point here in the year following diagnosis, women had a 5 times increased risk of dying from cardiovascular disease related to, women with endometrial cancer had a 5 times greater risk of dying from cardiovascular disease compared to, again, the general population. So these women are at a greater risk of developing comorbid conditions. And we know that cardiovascular disease among women is a topic of interest because we have a number of disease or sex-specific risk factors, as well as under-recognized factors or factors that are well established. And if you look at the under-recognized risk factors, these can be related to gender as well as the interaction of a woman or the interaction of a woman with a social and physical environment. So we're particularly interested in study that. I've been learning a lot about it with my dear colleague, Dr. Colleen Norris, because we have sex and gender-based inequities. We know that cardiovascular disease is under-recognized and understudied in women. Again, if you think of the traditional cardiovascular or the traditional views of cardiovascular disease, it is a disease associated with men or a man's disease, and women are certainly underrepresented in clinical trials. And again, as Dr. Norris will passionately advocate for, we need to be conducting more sex and gender specific analysis in studies that have been published. So we're certainly trying to address this gap in our ongoing research in my team. So when you think about women with endometrial cancer survivors, who are endometrial cancer survivors, who are at greater risk for developing cardiovascular disease, and if you think that, you know, once they treat the cancer, they are undergoing this survivorship care plan. Now, if you think about how our healthcare system works, and actually healthcare systems across the world, most of them, we know that a survivorship care plan is almost inexistent in a number of places. So only a small group of patients may actually receive a multimodal intervention or interventions that are focusing on exercise, on nutrition, as well as mindfulness counseling, because of the workload of care teams, and as well as because of a variety of other factors that we don't have time to discuss. But survivors of cancer, or people who are free of cancer, better term, they really have very unique healthcare needs. And they need quality survivorship care, which is going to be providing prevention, surveillance, and management of new cancers, as well as addressing side effects that have been, you know, consequences of the cancer and cancer treatment, as well as chronic diseases such as the comorbidities that we've discussed previously in women with endometrial cancer. So health promotion is particularly important for these individuals, and for a prolonged effect or benefit, we've also need to teach them about self-management. And this is best achieved, as we know from the literature, using multimodal interventions. So a number of interventions that are targeting their health and their healthcare needs that we know can improve physical function, quality of life, survivorship, and a number of other outcomes. And these multimodal interventions, so again, addressing important pillars of health like nutrition, physical activity, and mindfulness, can also improve or decrease the risk of cardiovascular diseases and having an overall benefit for these individuals. However, we know that these issues are really not addressed during a patient's healthcare journey. In fact, this figure here, just to summarize, because my time is up, about 40% of patients with a history of this cancer types, as you can see here, do not talk about diet, or actually 40%, so it's a very big number, don't talk about diet, exercise, smoking, and lifestyle change assistance with their healthcare providers. So that's very important, yet they don't talk about it. This is not addressed, but it's a very important concern for our patients. So here you can see the concerns and survivorship program preferences of survivors of gynecological cancers. So if you look on the left of the graph here, you can see that the most common survivorship concerns were fear of cancer recurrence, desire to lose weight, as well as long-term side effects. And people ranked the highest in terms of their priorities of what they would like to learn about in survivorship programs, nutrition, weight loss, and stress reduction. So this really lays the foundation for our ongoing research efforts, and that's going to be the part that Camila will talk to you today about. Thank you very much. I'll pass it on to Camila now.
So hi everyone, it's a pleasure to be here today. Thank you so much, Dr. Kenan, and also Dr. Prado, for inviting me to take part in this seminar. And today I'm going to talk a little bit about our resilience tribe. So as you can see here, we are in a big team of about 24 people from different areas, including nutrition, exercise, psychology, gynecological oncology, and also cardiology, among other areas. And we also have people in our team that have lived the experience of endometrial cancer survivors. So they are our patient partners. So our study acronym resilience stands for improving health behaviors for life after endometrial cancer. And this is actually the goal of our research. So we are evaluating the efficacy of a multimodal and digital intervention to improve several clinical outcomes such as excessive fat accumulation, cardiometabolic conditions, physical function, and also patient-reported outcomes such as quality of life in endometrial cancer survivors. So our study is a multi-site study conducted at University of Alberta and also University of Toronto. This is a randomized controlled trial with a two-arm parallel design that involves both components of quantitative and qualitative research. The study duration is of 24 weeks, and participants are going to access the intervention entirely remotely, and assessments are going to be done both remote and in person at baseline week 16 and week 24. So this is an overview of our study design. We are recruiting survivors of treatment for early stage low-grade endometrial cancer with obesity. And after baseline assessments, participants are randomly assigned to either the intervention group in blue or to the care group in yellow. So our study has two phases. The intensive phase, they are going to have access to a wellness platform plus healthcare professional support for 16 weeks. And after this week 16, they are going to continue in the trial for an additional 8 weeks, where they are going to use the wellness platform alone. So our study aims to evaluate the efficacy of this intervention, but also the sustainability of using the platform alone without the healthcare professional support. So participants in the intervention group, they are going to use this wellness platform daily. And the platform we are using in our study is commercially available and has been developed in Alberta by dietitians and other healthcare professionals. And this platform includes is based in three key pillars of health, including mindfulness, physical activity, and nutrition. And participants will use this platform with healthcare professional facilitated online support through one-on-one and group sessions with registered dietitians, mental health therapists, and exercise professionals for the 16 weeks. And then usual care controls, they will receive at baseline handouts with general information on physical activity, health eating, and health awareness. So this would be basically the care that they are currently receiving in the clinics. So I'm going to talk a little bit about the features of the platform we are using in our study. So the platform has 3 main sessions, as I said to you. The first one is called mindfulness, and where participants are going to reflect about their day through the daily reflections. And with this tool, they can identify challenges and goals for their health. They can also track their progress, and they complete stress assessment at different stages of their participation in the trial. And they also have access to different meditation practice that they can be including in their daily routine. In the nutrition section, participants can have access to a meal plan. So they can build a meal plan based on their preferences, also their budget. And this meal plan has different recipes that people can use, and they have different. So these recipes are from different ethnic cuisines. And with the meal plan built, they can have access to a grocery list. So basically, everything that they listed in the meal plan can be translated to this list and can be adaptable to the number of people they have in their homes. Participants also have access to a library of recipes and the Vivapedia, which looks like an encyclopedia of nutrition terms and also nutritional facts of common foods. In the physical activity section, participants can build a fitness plan based on their time availability and also the availability of equipment and their preferences. Participants also have access to a fitness schedule, yoga classes, and a fitness library where they can find tips on how to exercise safely and also other things about physical activity and its importance. In addition to 3 in addition to these three main features, there's also a health coaching. So weekly, participants receive a motivational quote and also coaching tips to improve their health in several aspects. And weekly, they also receive an email with their wellness journey that was developed in partnership with the company, targeting specifically endometrial cancer survivors. So our primary outcome in this trial is to evaluate the efficacy of the intervention, of the intensive intervention on waist circumference. And we have chosen waist circumference because it's a surrogate marker of visceral adiposity, which is strongly associated with cardiometabolic conditions that Dr. Prado mentioned in the first part of it. And as I said, we are also evaluating the sustainability of our intervention on our primary outcome. So this is waist circumference at week 24. And there are other outcomes that we are looking at week 16 and week 24, which includes body weight, fat mass, and muscle mass. So we can evaluate sarcopenic obesity with the addition of muscle strength as well, metabolic syndrome, cardiac function, and cardiovascular risk, fitness, and quality of life. We are also assessing physical activity and dietary intake, and we are going to explore this as exploratory, explanatory outcomes and other variables as well. So as I mentioned, we have a qualitative component of our research.
Hi, Camila.
Mhm.
We're very tight on time, so perhaps you could take a minute to jump to the outcomes and share that with the group, and then we'll come into the panel.
Okay, so Dr. Kendall, actually, this is a study that we are about to start.
Oh, okay.
So yeah, we are about to start recruitment and we don't have outcomes. So I'm just finishing up. There are two more slides, this one. So this is the qualitative study that we are doing to evaluate the experiences, preferences, and challenges of participants with the intervention, which is going to be very helpful for us later on to transfer our results to the real world. So we are evaluating this through a qualitative study. And also we have a patient engagement project based on the guiding principles of sport that includes inclusiveness, support, mutual respect, and co-build. And just to give a brief overview of this patient engagement strategy that combines a little bit with research participants as well, but basically it has three parts. In the first part, we are identifying patient engagement strategies for digital interventions in cancer survivors overall. In part two, we are consulting with endometrial cancer survivors on the design of our resilience trial. So this is really important to us to evaluate if our trial is going to be meaningful for participants or not. And in part three, we are integrating the patient engagement strategies identified into our trial. So this is the overall overview of our study, and I would like to thank investigators, supporters, and also funders. Thank you very much.
Thank you so much,
Camila. I think that leaves us with exactly 8 minutes to bring it all together and have a panel-like conversation. We did have a question in the chat asked by Madeline, and I see that Dr. Ogilvie has responded to that, so I'm going to skip that. I'm wondering if anyone in the audience has a burning question where you can unmute your mic, put on your video if you feel comfortable doing so, and have the stage for a quick 15 seconds to ask a question. I have a lot of questions, so.
Hi, it's Madeline.
Go ahead.
If you don't mind me continuing with that question, I remember, because I'm old, I remember how when moving to HPV came up as an issue and how we were going to deal with cervical, with chlamydia and other STDs, and wondered if there was any, and I haven't been following this in the last couple of years, so my apologies, but I'm curious about how we would be tracking, or is there a possibility of a research study that will look at STD prevalence in this population compared, but not doing it with the timelines we normally see with STD data, which is a couple of years behind. Has there been any thoughts of any of trying to drill into that? Because it's one thing to say it, but it's another thing to manage it.
Yeah, thanks. And I'll try to answer super briefly on this.
Yeah.
I think what you've named is really important, is that we've built a lot of our health system. It's a legacy on a technology that is frankly perhaps not a great technology, in fact, a bad technology. And so we leveraged a bad technology for practice that should have been sort of independent of that. So I always just remind folks that we would never want to not give the best technology because we're relying on bad technology for something else. So I think it's important for us to continue, and I didn't want to put it in the chat, but we are working with the Department of O&G here to actually really structure what sort of reproductive health should look like in the era of, frankly, better cervical cancer screening. And, let's stop relying on this poor technology to catalyze that. The challenge of course, of STIs is, and, we've got Gina Shoveler here, who is sort of one of the Canadian thought leaders on this, is the one way to make sure you don't is, I don't agree with most of what Donald Trump says, but one thing he said that was accurate, which is that one way to get your numbers to go down is to not do a test. And so as we do fewer tests, our numbers will go down. And so I think you make a really good point. What we actually probably should be monitoring is volumes, not so much the actual case numbers. And I think what you're really speaking about is, screening has huge benefits. It also can potentially have harms. And we need to be mindful of both the benefits and harms and have a very thoughtful reflection on it. So we have been sort of focusing on that, but yeah, thanks for re-upping that as well.
Thank you for that question. So I did have a question, and it's for Neesha, actually, because Simone and I had promised we'll put you on the spot later during the panel. I was wondering if you could shed some light into the diversity audit that you did, because I think that there's a place to make this more the norm than the exception. And so I just wonder if, for the sake of the audience, you could share some light if you do know about the diversity audit that was done. And if you don't, you could just answer another question that you think of.
Unfortunately, that is such a good question. And I agree that, including things like diversity audits in our work is such an important thing to normalize. Unfortunately, it happened before I came on board with the Move-In Project. But I could maybe speak to how we are incorporating diversity into our Mother Matters revitalization that we're doing.
Please do.
And that I think is really interesting as well, because we talk about digital practices and digital innovations. And as someone mentioned, we're kind of revitalizing the Mother Matters platform to make it a little bit more technologically current. So it was originally developed in 2011. And so tech that was developed then is quite outdated and doesn't really meet standards now for what people expect of digital technologies. And so as part of this revitalization, we've partnered with community organizations that really pay close attention to and have high populations of both Black mothers and adolescent mothers in the Greater Toronto area. And some of our work involves speaking really closely with mothers in these subpopulations with lived experience in having postpartum depression to understand what the unique and nuanced needs that they have out of a platform like this, so that we make sure that things like language, which was covered in the diversity audit, things like even content, right? What is relevant to a racialized or Black mother? What is really relevant to an adolescent mother who's battling postpartum depression? How do we make sure that our language and our content and our delivery of these things is appropriate and effective for these subgroups, is something that we're working really closely on. And these are relationships that involve, in-person human connection and are harder to foster online, not impossible, but definitely harder.
Yeah.
And so, it's this balance of doing things in person and speaking to representative groups in person and translating that knowledge into the virtual sphere.
Thank you so much, Neesha. And actually, you've given me nice fodder to segue into my next question, which is going to be for Nadia. Speaking of this need for connection and relationship, we see, like, your study showed that there was good uptake and acceptability, right, for the program. I wonder if you reflect on to what extent is this also a signal of dwindling trust in healthcare services, where people are now feeling like if I'm digitally empowered and there's a digital option, I would rather take care as much as I can into my own hands because I feel safe and comfortable. Wonder if you could speak to that.
Yeah, I think that, again, providing different options for people is going to be the way to go. Some people will still want to be able to see a healthcare provider, but also among given healthcare provider shortages in Canada and particularly in BC, sometimes it's just not an option whether there is trust or not. So I think, again, just having the option to do self-collection if you'd like, perhaps in the future, pending healthcare system, if there can be more healthcare providers, then that can be an option as well. But I think at least to get that screening done, and then if someone is HPV negative, they're good for 5 years. And then if they're positive, then they can kind of get into the cascade of care that way. Gina, I don't know if you have anything to add there.
No, I think that's exactly it, is we've really committed to options and meeting people where they're at. So a digital solution is right for many folks. I think the reality also is, though, the healthcare system as it stands right now, even if people had trust, doesn't work for people in that, particularly for the women that we work with, they're working night shift jobs. They have to find childcare. They get paid hourly wage. So to step into a doctor is actually is not neutral. It's a hit on them. And so the digital option may not reflect their keenness on it, may not reflect anything about trust. It's just the healthcare system doesn't work for them right now.
Yeah, access.
Meeting them where they're at. Yeah.
Thank you so much, Gina. And honestly, I would have loved to take this conversation much, much longer because there's a lot to talk about, but we want to keep to time and want to wrap up. So it's my pleasure to hand it back over to Kendall to please close us up. Thank you all so much for your insights.
I also really want to express my appreciation for the wonderful moderation and this excellent panel that I think really highlights. And as we were having this last conversation, I could see many of us nodding, you know, about all of the very basic barriers that many women and gender diverse people continue to face in accessing care. And sometimes we think that out of crisis can come opportunities. So we can recognize that our healthcare system is in a crisis in this country. And as we move forward, I think we want to see ways to address women's actual health needs and their access to the health system that include these wonderful digital innovations within. And just for me, I was excited to see in the Fraser study that in that group of women, 82% said that they were using the internet every day. So that is showing us that this is a place where populations that are sometimes called hard to reach can be reached. So that's very promising. Power thanks you all for participating, and I wish you all a wonderful International Women's History Month and a welcoming to spring. Have a great day.